Welcome, everybody. I'm really happy to see so many familiar names and faces. Um, Today, we are having this seminar led by Lígia Parodi. And this seminar is one of the series of workshop seminars which we are prepared for community health workers and peers working in HIV and HCV and TB prevention. And this workshop is taking place within the CORE project. CORE is the European Union project, and its main goal is to reduce inequalities in HIV, HCV, and TB prevention and treatment. And in work package 4, we are focusing on capacity building on community health workers and peers. And we want to talk specifically about intersectional vulnerabilities of our key populations. And this project is a 3-year project, and now we are in year 2. And following this year, after the workshops, we will be creating a capacity building tool, which will be available online. Important information is that this seminar will be recorded, and the recording of the seminar will be posted on the CORE website. By the way, on the CORE website, you can also find information about the upcoming webinars and also recordings of the previous seminars. I forgot to introduce myself. My name is Sasha Gurinova, and I'm working for the work package 4. Deutsche Hilfe is leading work package 4 on capacity building. And now, my very warm welcome to Lígia. Lígia Parodi is a feminist, harm reduction activist, psychologist, mother, and drug user. She is based in Porto, Portugal, and she is a member of CASO, which is a Portuguese association of people who use drugs, where she contributes to peer-led harm reduction and human rights initiatives, especially with a focus on women. She currently coordinates the advocacy team of the European Network of People Who Use Drugs, Euro-Input, and she is also a member of the women's team Sisterhood. Lígia is also a member of the advisory bodies of the Women Harm Reduction International Network and the International Drug Policy Consortium. And Lígia will be talking about barriers which are facing women in accessing HIV, HCV, and TB treatment and prevention. Lígia, I'm really happy to have you here today with us. Please, the floor is yours.
Thank you, Sasha. I'm also very pleased to be here with all of you. And I thank you so much for coming to this session. So I will be justifying, I'll start by justifying why the title of this workshop and moderating a bit the way that it is put, because when we talk about community-led responses and community-based responses, it's not that you have opposition. You don't have opposition. You have a continuum of answers, of responses, and kinds of organizations. The community-led we will be defining, because one of the needs is to define what is this community-led responses and community-led organizations. And I will draw on peer work and on community-led examples to discuss and understand what has been done and what else can be done, the extent to what peer work and ways to develop and support the peer work and the community-led organizations. And in this particular context, led by women who use drugs and or responses to expand, to access, and to monitor HCV and HIV services. So it's quite a challenge that I've put for us. The goals for this workshop, and I want to take some time to go through the goals because I would like a bit later to have your answers about how do you relate to these goals. I will propose 4 goals, and I want you to tell me in the chat, please, which goals are you relating more? So the first goal is to develop community-led and community-based gender-responsive services where they do not yet exist. Second goal is expand existing gender-responsive services to reach to intersectional priority populations. The third, expand existing community-led and community-based services to include a focus on disease areas that affect newly added priority groups. The fourth is to improve the quality of existing services, especially levels of community participation. We will have, our session will have around 2 hours. We will finish before the 2 hours if we manage to do it, and we'll have a 5-minute break. I was proposing 10, but Sasha asked for 5. You must have this one, Sasha, but okay, let's do 5 minutes pause when it arrives. I think we all more or less know the house rules, how this kind of situation can better work. Not talking everyone at the same time. But I want to tell you that I encourage your participation because this issue is in development. We must work together to have better results and to achieve these challenging goals. Going on, so one of the things is to differentiate and to define what are community-led responses and what are community-led organizations. In 2022, a global peer work consultation with your input contributions, including your input contributions, got together and worked what are the recommendations from the civil society group to the AIDS strategy. So these definitions are in that document, and the community-led responses are defined. Sasha, if you can put the next one. Okay. No. Yes, this one, thank you. I also asked Sasha to put all the links to the documents that are available in the chat. There are some of the documents that have a QR code that will take you to that link. But because it's not very helpful for everyone, I asked Sasha to put also the links in the chat, to share with you the links in the chat. So, what are the community-led responses? Actions and strategies that seek to improve the health and human rights of their constituencies, that are specifically informed and implemented by and for communities themselves and the organizations, the groups, and networks that represent them. So it's not only worked by people that are affected, but also they are decided, they are designed, they are informed and implemented by people and for people of the communities. The community-led organizations are these groups, these networks that can be formally or informally organized and that are led and staffed and spoked, and their members and their volunteers belong to this to the community. They reflect and represent the experiences and the perspectives of their members and their voices of their members. So, community-led organizations, groups, and networks are self-determining and autonomous, not influenced by government or other, and not all community-based organizations are community-led organizations. I hope we'll have I'll have some feedback from you about this, the clarity of these definitions, because I think it is important. But one thing that I want to say is that there is no opposition, and there is kind of a spectrum between what is done, the initiatives of community-based organizations, these responses. There is a continuity until the community-led, because more and more it is recognized that the populations affected, drug users in this case, and women who use drugs particularly, have to be involved in the services, in the design, in the monitoring, and in the leadership too. We don't have an opposition, but I think you agree with me that we have a continuum. So, but this definition was an answer by a group, one of the answers or one of the recommendations that a civil society group gave to the AIDS strategy, 2021-2026. Can you show the next slide, please, Sasha? Yes, this one. So the AIDS strategy, 2021-2026, we are more or less in the middle, I think more than the middle of the period, and there is already some opportunity to assess what has been done. Is it achievable or not? What was proposed to this period of years? The Global AIDS Strategy recognizes that communities and people affected have a crucial role. The communities are the capacity of community-led responses towards key populations, youth, for instance, is crucial for the ending of AIDS. Until 2030, this is the goal established. How crucial is this response, the community-led response? How crucial is it for the AIDS strategy? Well, we have some quantification. The strategy gives us some quantification to know how much of the response should be community-led in order that we can achieve our goals. And the strategy talks about 80% of services for women, including the prevention service for women at increased risk of acquiring HIV. The service delivery should be 80% should be done by women. 30% of the testing and treatment services are delivered by the community-led organizations. And 60% of the programs supporting the achievement at societal enablers, we will understand better what that is. What are the societal enablers that are so critical to achieve the goals? They must include the key population that they are working towards in 60% level. I always thought that these goals are very ambitious, and in 2024, July 2024, I don't know if you agree, but it's already very clear that these goals will not be achieved by 2026. We are very far, very far. So we need to contribute to this, and I will now ask you to introduce yourself after this introduction, to introduce yourself and to tell us your name, to tell us your country, your organization, your role, which key populations are you addressing, are you working with, if that is the case, and with which goals of this training do you relate more? Is it the A, the B, C, or D? All of them, or one of them, or two of them? Yes. I will just remind again what are the goals, because I would like to have the feeling of the interests in the people that are attending this workshop. And the goals are to develop gender responsive services. This is the root. There are no services, and for women who use drugs, gender responsive services, and how can we develop? Is this your goal? How can we develop these services? Or there are already some services, but they are not reaching some of the intersections of the population. Is this for instance, if there are populations, new populations, let's say, intersectional populations like transgender, migrant, sex workers, is there this particularities that is this the new population, but also not only how to reach, but how to engage people in health services, and including the focus on diseases that affect these newly groups, priority groups. We can be talking about, for instance, tuberculosis in a specific group. Or are you in a context that you already have the services, but you want to improve the quality of the existing services? And one of the strategies, one of the ways to improve the quality must be increasing the levels of community participation. The community must participate since the design, in the implementation, in the monitoring, and in the advocacy too. So I will ask if if you can add something more to this chart of key populations, priority groups, and possibility of intersections. So who are you working with and thinking of? Is it women? Is it women? Is it people, gender diverse people? Are they sex workers? Are they young? Are they very young? Or are they old, very old, and or not very old, but in an age that there are health consequences of drug use that will justify that you focus that group, a group of people that are maybe you cannot even say old, but aged drug users that will start to have some specific health issues with the circulatory system, for instance. Or is it a priority group? Is it a racial? Are they women from racial minorities in your country? Or is there a question? Are you dealing? Are you thinking? Are you advocating for women who use drugs that are pregnant or that are mothers? All these situations will open a new intersection of barriers in specific services that these women need. So please, can you tell me if you want to add some more groups to this list? And if you think that harm reduction and HIV and HCV services in your country or in your context, in your city, are taking gender into account. Do they respond to all women who use drugs needs? What do you think is the probability that a pregnant woman, migrant from sub-Saharan Africa, say in Spain, accesses needle and syringe programs and HIV and HCV prevention and treatment services? Do you think these women will access these services? Or another example, what is the probability that a Black trans woman and sex worker, say in Ukraine accesses says in Portugal, let's bring closer the example. In Portugal, accesses a drug consumption room. Damas, please.
Yes. Honestly, I'm very pessimistic in response to your questions. I don't think that that there's reliable access, and I think that although I know admittedly little about this, but also I think that one of the biggest problems is that people don't know. I mean, the clients themselves don't know where they could go, and that's where I can see a huge challenge, right? Where are these services? Do they exist at all? Because they don't exist in Central Europe, for example. So I mean, there's no place to go there. And so for me, that's the biggest problem. How can you reach these populations, these people, and how can you make sure that they have not just access to these resources, but they also have the trust to access these resources? Because there I can also see a huge challenge, whether you actually are trustful enough to go into these services.
So your question is, the services exist, but women don't access those services. Is this the question?
Yes, because they don't know if the services exist, or they don't know where they are, or they don't trust these services because they don't trust the system, so they don't necessarily trust the services. That's my question and challenge, and so this is what I've been thinking about.
Thank you. It is a concrete line, and we will address some of the questions that you put. Rui, you also have your hands on the air.
Yes, thank you. You were talking about the example of Portugal, and I feel we have progressive policy, and yet we don't have this kind of gender sensitive services. And so women can access services, but services that most of them are designed for men. And I would add another key population that I feel in Portugal and in poor countries are increasing, that are the people that are homeless. And I feel that women in homeless situations are going through even more violence than in other situations. I saw in the chat someone talking about the authoritarian regimes in the Eastern Europe, and I feel so. I agree with Thomas that the landscape, the things we can see now, they're not very optimistic, and I mean, we have a progressive policy, and it's hard to have the services. So in authoritarian regimes where harm reduction is seen as an incentive to drug use and so on, I feel it must be even harder to develop these services. Thank you.
Thank you, Rui. Yes, it's harder, and we know, particularly in Portugal, about initiatives, but also about the very progressive and very slow change that we assist. And we must be aware that Portugal is indeed a hostile context if we compare with so many contexts around the world and even in Europe, because Portugal decriminalized the use and possession of all drugs in 2001. So we are indeed in a favorable position to develop work in this area, but we know how difficult and progressive it is. It's not all bad. There is some progression, and we must talk about some steps that we were taking. Not at all saying that they are the most successful steps, but giving the example as a way to progress and a way to develop and expand some gender responsiveness.
Yeah, can I add just the positive parts? I, in fact, with Caso and with Gat in Lisbon, we have been trying to develop mutual support groups.
Please don't go there yet.
Okay.
I'm keeping it. I'm going to slice to go by slices, and we will arrive there. But I would like.
There's good things also, but small in small scale. Yeah.
Yeah. We will talk about that a little bit later. We'll start looking, we'll try to be a bit systematic, and we'll start with the question of the availability of services. And because one of the situations can be there are no services available, or are there services available, and where are they? So the availability of the HIV and HCV prevention, including harm reduction, do you know if they are available in your country, and do you know the coverage of these services? There is some excellent data to discover if you have an idea in your context, but you want to know about it in your country. There are some reviews available. One of them is you have that the links. Sasha will put them in the chat too. One of them, very recent, is on the Lancet, this global coverage of OAT and needle, so opioid agonist treatment and needle and syringe programs. What is the coverage of these services? In that link, you will find the data provided in 2023. It is a very wide and a comprehensive overview on the service coverage level, not only on each service, say needle and syringe programs, but also the combination of needle and syringe programs and opioid agonist treatment. Why are we talking about these specific programs when we talk about the testing and the services of prevention for HIV and HCV? These programs are considered by the UNODC, by the UNAIDS. You have it in the next slide. They are considered the priority services. priority services to achieve the goals and the targets of ending HIV and eliminate hepatitis C. It is not possible to achieve these goals if you don't have needle and syringe programs and opioid agonist treatment. This is considered by the several organizations and governments. We will argue that much more is needed and not only these priority services. But let's consider that these are priority services, and we know that although these interventions are supported by WHO, UN agencies, and they are essential to achieve the goals on HIV and on Hep C, the access to these interventions for people who inject drugs, such as needle, NSP, and OAT, they are far from being adequate in many countries and regions. Less, says Harm Reduction International, less than 1% of people, all people who inject drugs, live in settings with a high coverage of both needle and syringe and OAT. This was the situation in 2018. Checking the differences for the last numbers of last year, of 2023, you will have some increase, but a very modest increase in these numbers. This was the situation in 2018, and it still is. And we are talking for people who use drugs and for people who inject drugs in general. And what can we say about women? In 2016, the UNODC notes that women who inject drugs have less access than men to harm reduction services, even where they are in place, and are more likely than their male counterparts to acquire HIV. So, this is why we need to improve the efforts to better reach and better support all women who use drugs. Progressing a bit, because we are putting our focus to a more specific, a gender-specific reality. And we saw before that there are several data available. It is also the European Agency for Drugs that has data. Some parts of the world have much more data than others, and data is very important to know what is the reality and to improve the reality, the access, and the availability. So we have that evaluation generally for people who use drugs and for people who inject drugs. But what about women in that universe of people? What happens with women? Women have less access to the services, health and harm reduction, and have higher rates of transmission of HIV, of HCV, and less smaller engagement with treatment. We know all this, but in what extent? So, is there some community-led monitoring on the availability of the services? And I must say, I must present you a very important work from Women Harm Reduction International, which is called Global Mapping of Harm Reduction Services for Women Who Use Drugs. It was the first year it was done, was 2022. And now there is in progress an update to that global mapping. It is in progress now. Women are estimated to account for 1/3 of people who use drugs globally, yet are consistently reported to have less access to harm reduction services and to be at higher risk of HIV and hepatitis C infection. The tools do exist to enable harm reduction services to increase their relevance and reach the women who use drugs. This includes use of gender lens and gender mainstreaming in planning and the service delivery. Services have to introduce these approaches on the ground, and where they do not exist, where they do exist, where they do not exist must be implemented. When they do exist, they must be monitored and evaluated. It is difficult, if not impossible, to document and promote the outcome, but usually there is no data, or there is no robust data about this subject. The research on drug use and related health issues rarely produces information about women and harm reduction. The global mapping is one of these exceptions. There are some support for community monitoring of the responses that are in place. For instance, this tool from Input, it has been developed by the International Network of Women Who Use Drugs in collaboration with UNODC, the HIV/AIDS section. And it is based on a policy brief, the policy brief, Women Who Inject Drugs and Addressing the Specific Needs, and is a companion of the practical guide for service providers on gender response HIV services that we are now going to have a close look. So the Input tool was developed for monitoring the existing harm reduction services. And the answer it provides is, in what extent are these services adapted or working with women who use drugs, women who inject drugs, and towards all the services. So are women needs provided for in these services or not? This is one way to approach the situation on monitoring the situation. What monitoring and assessing, you must talk with people. We must talk with women. Women who use drugs must have a very important say on what is needed, what isn't there, and what must be adjusted. And all the documents, we will go towards more the realities in a while. I want to give you these tools so that you have some concrete ways of proceeding if this is the questions you have, how to monitor the services that exist. What are they not answering to? So the input gives us on the agenda with this suggestion, with this work, they give us a structured way of evaluating with the women the quality and the extent that the services are that are needed, in the extent that they are available. So I was telling you, you must talk. Women who use drugs must talk about it, must be heard about it. And I want to take the time to show you an interview that was done some years ago. It was in a specific context, but it really it is adjusted for this moment, because we are now asking about the barriers that women who use drugs face in the access to services. And one sister, she's not among us anymore. We interviewed her some years ago in the scope of a project called Street Report. We were asking and filming drug users in Portugal, asking them what is not working, what must be done. And some of the interviews were with women, one of them Giti, and we have this 5-minute video to see with Giti's interview. Can we show it now, Sasha? Sound and everything.
Eu vivo numa casa particular, tenho um quarto com a minha companheira e mais nada. Anda na CAT, bebe metadona.
Ok, ia te perguntar isso, que drogas é que consomes?
Branca, metadona. Quando não tenho metadona, heroína, ou mesmo só quando não tenho metadona. E 2 em quando um chá na noite.
Em casa, na rua?
Mais na rua. Porque tu trabalhas na noite, tens dinheiro, compras. Trabalhas, tens dinheiro, compras.
Costumas consumir com outras pessoas ou estás sozinha?
Normalmente com outras. Sim. Tu encontraste sempre uma pessoa e uma pedra também, dá-me pouco. Mas na rua eu fumo mais, ou em casa injecto. E quando eu tenho um sítio na rua também injecto. Na rua é complicado. Yeah, porque é respeito de outras pessoas também. Eu não gosto muito de pessoas. Yeah. Eu também tenho filhos, 2 filhos, onde tu pensas de outra maneira.
Sobre a lei propriamente dita, gostava de saber se conheces a lei que descriminalizou o consumo de drogas em Portugal. Alguém alguma vez falou contigo desta lei?
Não.
E, portanto, não conheces. O que é que tu achas que é a lei portuguesa? O que é diferente das outras?
Não sei.
Portanto, o facto de não ser crime consumir, não ires preso por consumir, achas que é bom?
Isto é bom, é.
Alguma vez foste apanhada pela polícia com drogas ilegais?
Aqui não.
Nunca
Não.
tiveste chatice nenhuma?
Não. Já tinha mais vezes revista, ou nunca tinha uma coisa comigo.
Mas sem violência, sem tudo tranquilo. Portanto, não te aconteceu nada, não foste a tribunal, não foste à comissão?
Não.
Ouves falar de histórias diferentes dessa, de pessoas que têm problemas com a polícia?
Sim, já mais vezes. Eu também me sabia, polícia batia pessoas e não sei com elas andam com motos lá dentro e muito agressivo.
Fizeste tratamentos? Como é que.
Eu na metadona, no tratamento de metadona. Sim.
És acompanhada, depois vais lá buscar metadona todos os dias ou uma vez por
Sim,
semana,
sim.
é isso, não é?
Todos os dias.
Sentes que eles te ouvem, que eles te escutam o que é que tu precisas, essa equipe que te acompanha?
Está bem, depende da equipe. Depende da pessoa. Uma quer mesmo ajudar e outra ouvir e no outro lado não interessa.
Quais é que são as diferenças quando estás a ser apoiada por uma equipe de rua ou quando estás a ser apoiada pelo CRI? Que diferenças é que achas, é que sentes?
Na equipe de rua tu sentes-te melhor, eu sinto melhor, porque tu pensas que uma pessoa de nossa. Na CRI, doutores, pouco mais distantes.
Sim, portanto, a equipe de rua fica mais próxima das pessoas. O que é que achas da possibilidade de abrirem espaços, salas, onde se possa consumir de maneira segura, com materiais novos? Achas que é uma boa ideia ou é uma má ideia? O que é que sentes?
Muito boa ideia, muito boa ideia. Porque eu disse respeitar outras pessoas quando infectaste. Precisas sempre escondido. Quando existe uma sala, tu vais lá dentro e ninguém vê.
Mais tranquilo?
Muito bom. Este para mim é um projeto que só falta aqui.
Portanto, pela privacidade, não é?
Sim.
Ninguém está ali a ver,
Sim.
também pelo acesso a materiais.
Mais limpa, mais higiênico. Tu ficas mais calma, não precisas sempre ver. E também pessoas, talvez, vai embora de cabeça, ai, drogadas, injecta tudo. Porque isso não assim. Não.
Também ajuda a combater o estigma à volta
Sim.
dos drogados.
Sim, sim.
Que outras coisas é que achas que um espaço destes poderia oferecer aos utilizadores?
Talvez um espaço para jogar futebol, table football, uma coisa assim, para encontrar, sim. Porque muitas pessoas também na rua, em frio, ou para comer, talvez, uma coisa assim. Yeah.
Dentista, achas que entre as pessoas que usam heroína e coca não seria um serviço importante de existir?
Sim, sim. Muito importante.
Mais algum serviço que achas que possa ser útil para quem usa droga?
Eu pensar que falta mais também advogados. Advogados para drogadas, ou para pessoas de rua. Porque muitos têm problema com justiça e falta.
Não sei se gostarias de dizer mais alguma coisa sobre o modelo português e a tua experiência cá em Portugal.
Eu sinto-me nesta parte de droga melhor aqui em Portugal. Porque eu disse, podes fumar um charo, não falta nada, ou tens uma passa no bolso e andas com calma. Porque consumo mesmo não é crime, consumo não. Consumo mesmo para mim não é crime. Consumo
Não é um crime.
não se não faz mal a ninguém. Eu não gosto de pessoas assaltam outras pessoas, eu mesma não, assim não.
Because she'd walked it about 1,000 times before. I guess that she escaped. It's such a shame.
And that I believe that Giti says almost it all. And she says almost it all when we ask about her life, and we give her conditions to be well in order to answer in in a well, in a good way, let's say. We are almost in the time for our pause, but I want to put a question before doing that pause. It is in our Sasha. I'm sorry, I'm going to mix up a little bit things. Could you give me slide 15 with a question about the examples of community-led responses or collaborative interventions after the needs, what we need, and now how are we going to implement it? This is the next part we are going to address. Yes, this part here. So I was talking about putting out the idea. Are we talking about same women when we say women who use drugs or women who inject drugs? The question is here, and if we are talking about HIV and HCV prevention, we are not talking about only the women that are in this moment injecting drugs. We are also talking about the women that have already injected drugs in some time or for some time. So I tend not to make any distinction. It's not, of course, the same risk, but I tend not to make any distinction because there are many women that have in some time in their life already had an injected use or still have, and we know that if you still have that use, it is the biggest risk. About this, the examples of community-led responses and or collaborative interventions, I'm going through afterwards, I'm going through point by point, some ideas for these collaborative interventions and about community-led responses. But I think it is a good time to make the pause. If you want, before going to the pause, want to ask something, please do. Well, no one wants to put, so maybe after the pause, we can start by opening, and maybe you can think about the things we have already addressed, and you can make some comments or question, okay? I will go on hoping that you are already there. And we will go on with the question, but how can we implement, what can we do to improve the community participation? And with this excellent tool that has the subtitle, well, it's called Implementing Comprehensive HIV and HCV Programs with People Who Inject Drugs. We will go from here, the general, to then the part of women specific, but there will be important information here too. This guide is from 2017. It's very timely, and the subtitle is Practical Guidance for Collaborative Interventions, and it was published by UNODC, Input, UNAIDS, and other UN agencies, and PEPFAR. So there was funds or good funds for this work. So there are lots of good suggestions on how to promote this collaborative intervention with people who inject drugs and with people who inject drugs and are in the most vulnerable situations, these key, very key people that will arrive in contacts that other will arrive, will reach places, will reach people that are not reachable by any other means, because they are not going to the services, they are afraid, there is stigma for lots of reasons. They are not going, and these peers, these peer navigators are crucial, are very important to reach people that are out of reach. So not even the outreach teams, nor the drop-ins, nor initiatives in prison, they are not reaching everyone that is in the need or that we want to reach. And we want to reach to achieve the goals of eliminating HIV and HCV. So what can be done? One of the ideas is that peers should, peer women, women peer should undertake outreach with some materials in a backpack and with a good training. Peers are able to take prevention, to take an NSP to the places where are people that and women that don't usually go to the services. So one of the ideas will be peers and women peers undertaking outreach. Also collaborating with the mobile unit, with the outreach team, but also this secondary needle and syringe distribution, which is this idea that peers can take and can provide the materials, the harm reduction equipments for the use of drugs with less risk. They can take it by their own. Also, peer education on safer injecting and risk reduction strategies to people who inject drugs. Why don't peers make demonstrations to other people who use drugs? Why don't women make demonstrations about way of injecting in a safer way? The places, all the need to do in a clean way. So peers are very powerful doing this kind of education. Also, peers can take dried blood spot testing and distributing self-testing kits if that is allowed in your country. Also, peers can support people who engage in treatment. It is very different after making a referral to an appointment, after a testing. It is very different if you have a peer supporting that appointment with the person that has the appointment, the consultation for following up and for accessing the treatment. If at least the first time you will have a peer that will support this consultation, taking the bus, going to that place, you will have more people will have more probably will adhere to the treatment. Also, in many places, we must talk about the online outreach, either with the dating apps or the online spaces that are used by people who use drugs. And the peer-led support groups. We will give an example of one of these groups afterwards. The support groups, the mutual support groups for people living with HIV and HCV, this is the example in this practical guide, but we must also add in situations of violence. When women are victim of gender violence, the mutual aid group can be very, very useful to empower women to share the experiences. There is a power in this kind of groups that is very worth it. Another example will be the cleanup operations. Not usually only cleanup operations, but a group of peers can target and remove the injecting equipment from priority drug using areas. And this kind of action is an opportunity to engage with people that are using those spaces for education, for contact, and well, this will be a promotion of the link and a way to bridge the gap between places where people are using and the services they need to access. So, said in another way, and in a brief guide that was produced by Input, once more, a brief guide about for people who use drugs. And there is a specific session for addressing the needs of women. So we can look, there is this, I brought you this small box with what to check for in the harm reduction services to know if the needs of women are being addressed. You can check for instance, if these services employ women and employ women that are part of the community. If the harm reduction service has childcare services available, do you have women that use drugs in your service and are mothers? So they have their childcare. There might be the need to have some services for the child care, so that the woman can go to the harm reduction service and have her needs satisfied. Also, harm reduction services should offer separate spaces or times for women. Sometimes the need is for a separate space, or maybe you can start making some time women only and develop and assess the needs from there. Another example, the sexual and reproductive health services should be available for women and also about rights. So sexual reproductive health and rights. This means several things. And we talked about pregnant women and women that have children. We must talk also about the right to abortion and how accessible is it for women. Harm reduction services should also provide legal support. Giti told us this. For mothers facing problems with custody of their children, and not only these problems. We are also talking about intimate partner violence problems, for instance, and how difficult it is that a woman will denounce, will make a complaint in the authorities about this situation. And harm reduction services should also provide support, counseling, and referral for victims of gender-based violence. Exactly what I was saying, yes. So this brief guide gives us a perspective about this. It's also a good tool, I believe. I'm going to show you now another example from this spectrum of intervention of support, treating, testing, treatment, and care. And I have this example in a very close to home edition, which is from Euronput, and it is very recent. It was very recently published. And I will highlight some of the conclusions of this work. It gives two examples of community-led organizations that are providing services for people who use drugs in this area of the HCV. Not only, but also. One of the conclusions is that these community-led approaches for HCV testing, treatment, and care are highly effective in increasing the HCV testing and treatment uptake and retention rates among people who use drugs due to their unique advantage in providing the privileged access. This access is a crucial pathway, allowing for multiple points of entry, essential to reaching both the treatment and non-treatment populations. The impact of peer workers and drug user activists on the expansion of HCV testing, treatment, and care is substantial. And it also recognizes that community members, particularly those at higher risk, play a key role in shaping and sustaining an effective HCV interventions. Okay, so about the way to expand services. This is what I wanted to show you, and I want to make a little bit of jump in my slides to the slides, which is it is 23. Yes, okay. Because we have already talked about this, the gender violence effect, how big of a barrier it is for women who use drugs. And how big a barrier it is for the access of the services. For many reasons, but one of the reasons is this, and it is quite a wide reason, let's say. And UNODC, once again, in partnership with Input and also RIN, among others. RIN, we already talked about it. It's the Women and Harm Reduction International. And UNODC recognizes the constant engagement and substantial contributions throughout the development of this briefing paper, recognizes it was essential, and the voices, they ensured that the voices of the community and civil society were embedded throughout the paper and its recommendations. So it's an example of collaborative advocacy, let's say, because the UN Agency for Drugs and Crimes collaborates with drug users, organizations, community-led organizations to build a very important and very interesting and very practical guide called Addressing Gender-Based Violence against women and people of diverse gender identity and expression who use drugs. I will not make a sum up of this document because it is important. It's impossible. I'm going through this in phases, so I believe it is usable in that way. But I want to bring an example that is put there, is in this document about Klub INI in Kyiv in Ukraine. I must give you some background on this. So in Ukraine, 1.1 million women per year experience gender-based violence. There was some focus groups done in 2018, listening to these women, and all the participants reported violence from their partners or family members. With these results, in 2018, Klub INI began providing gender-sensitive and non-discriminatory gender-based violence prevention services for women from the target populations who have experienced violence. They piloted a project with gender-based violence screening, brief interventions, and referrals to a treatment tool, a wider situation called WINGS. The treatment tool would include the intervention in several areas, kind of in a comprehensive package of intervention. In 2019, they went on conducting a research that confirmed the very high prevalence of gender-based violence among sex workers and women who use drugs, and serious gaps in service for them. The services are in place, the authorities are there, they should have received the complaints from every woman that is targeted with the violence, gender-based violence, intimate violence, whatever violence, but they actually don't. This is seen also in Portugal and everywhere, I believe. So it is important to hear the women, to know the prevalence, and to understand what are the gaps of the between the needs and the services, like these services for violence victims. Do these services, are women who use drugs accessing these services? What about shelters? are women who use drugs going to the shelters, went to shelters to women that are victim of violence? Are they going to these shelters or aren't they going to these shelters? So the question is, they should, but usually you will see that they are not, or the extent they are going is very narrow. So going on with Club INI and finishing this part, in 2021, 20 and 21, with the support with the United Nations Trust Fund, WINGS, so this comprehensive program was provided to more than 1,600 survivors of gender-based violence across 8 regions in Ukraine, and a shelter for women who use drugs and face gender-based violence was opened with the support of Women Harm Reduction International. The need for a national advocacy campaign to promote the shelter model for women who use drugs is evident, and the organization is working with women organizations in 9 cities to expand these services. So I believe Club INI is a very interesting and a case study with this intervention. So there are other examples. I would prefer to listen to the examples from you. Is there someone that would like to give an example of a service addressing gender-based violence for women who use drugs? If you have an example, please, except you, Rui, I'm sorry, because the example you would want to give, I worked on that to present here. Thank you. Is there any other? Yes, there is. Dorcas, can we hear you?
Yes, please. Hi, good evening, good morning, good afternoon. My name is Dorcas Kimotho. I work for Women Nest in Nairobi, Kenya. Women Nest is a community-based women who use drugs-led organization, plus women in harm reduction, activists in harm reduction. So it's purely women. What we have done since 2019, 2020 during COVID, we had a lot of women who use drugs becoming homeless. So our first entry point was to start shelters for the homeless women. But as we continued offering shelter, then the other issues that raised was continuous gender-based violence among the intimate partners. So we have been sheltering women, and as for today, we've had sheltered more than 100 women who use drugs. And the dynamic of shelter is that we are also having them with their children. Some are even getting pregnant while at the shelters. So we now start the dynamic of looking at a woman who uses drugs plus her child. Those from prison are also welcomed in the shelter. So ours is a dynamic shelter. So we have those who've been incarcerated, they've done their jail term, they are out. Before they reconnect to their families, they are welcomed in the shelter. Before they are integrated in the social reintegration, we have them in the shelter. Thank you. That's what I wanted to share. Thank you.
Thank you, Dorcas. It was very good to hear you talking about your work. Someone else, would someone else like to share a bit about the initiatives, some initiatives? I will proceed with some examples of community-led community-led initiatives. It is one of my favorite examples, and it concerns how I'm talking about campaigns, 2 campaigns mainly, and they are usually, these campaigns, an opportunity to engage with women that were not engaged so far, engaged in the organization, engaged in a group, engaged in the health services. So these campaigns can be very useful initiatives to go on to reach women that were not in the, let's say, in the radar. We ask women we know or people we know. We can ask men we know, because usually or many times we find that women, men are have a relation, an intimate relation or not so intimate relation with women that might be asking this man to ask for at drop-in or at the outreach team, ask them to get the use materials, get them the needle and syringes, get them sometimes even opioid agonist treatment. And this is one of the reasons that we see that usually women arrive later to the services, to the health services and to the harm reduction services. They engage later because there might be this phase that they are not going to show themselves in the services, although they need, and there is this relation that will justify that it will be the male partner that will ask for, will ask for whatever, saying it is for him, but instead it is for him and for the woman that is waiting at home, for instance. So in this kind of campaigns, I find very powerful in this engagement. Then, of course, there must be something else afterwards to solidify these contacts. But many times campaigns are a very important moment of engagement, not only with the women who use drugs themselves, but the community of people that are from people from the services, professionals, families, friends, and if you make it in the street, also people in the street. I'm talking about mainly targeting the question of gender-based violence. There is this campaign, Everwood, Elimination of Violence Against Women Who Use Drugs, since 2019. RIN initiated this campaign, and it is nowadays being, celebrated, let's say, or developed in several places in the world. Portugal is one of them. The other campaign it's not yet this one. Afterwards, I'll go to this one. This campaign, the other campaign is Support Don't Punish, with a focus on women, also a RIN initiative. And it is the part of Support Don't Punish that focus on women. This will be the 26th of June, and the Everwood campaign is a 10-day. It's not only one day. It's from 26 November to 10 December, if I'm not missing the dates. And so if it could be possible that after a campaign and after this engagement, these new women that you are knowing that other peers brought them, or maybe even their partner or their friends, they arrive to you, and what can we do? Well, one suggestion is a mutual support group. Mutual support groups have shown very positive results, not only in the field of health, but also through sharing experiences, information, and strategies to deal with their common problems, and promoting citizenship and associative initiatives. So one example I know very close, and this is why this is the one I'm going to talk about, because I can talk about it in more detail, is the group MUSA. The background of this group is the association of Portuguese users, that started in 2007 and formalized in 2010. And it aims to meaningfully involve peers in the promotion of health and dignity of drug users. I'm going to tell the story like this, and Rui might want to correct me in something, but, well, you know, stories, the narratives are very individual. So this is mine. In 2016, I'm going to tell this in small bits, briefly, but in small bits. 2016, 2018 are for me the years that Caso started intentionalizing a focus on women, making sure that women would get involved. One of the initiatives we had was a photo portrait workshop that would normally be opened to any drug user or any member of CASO, or male or female. But this time we decided to use a number clausus, meaning that it couldn't be, we had money for 8 people to attend this workshop, and we decided that 5 of these places would be for women and 3 would be for men. Well, we decided, and we wanted to try out this, because in similar situations before, we were calling all drug users for some kind of situation, training, or campaign, and usually only male drug users were showing up, or maybe one female drug user. And we knew that we wanted to motivate women to go. And this was the way that we thought about things. How can we bring women? So we tried several things. One of the things was to make this, we had more places for women than men, for compensation, let's say. And we were also offering more money for a per diem for the participation, a higher per diem for women than for men. Why? Because women were losing more money if they would give the time for this. So going ahead, 2019 was a very important year, was a kind of a golden year, because there was several things happening. One of the things was the Harm Reduction International Conference and a pop-up safe space for women who use drugs. This allowed women that were participating in the conference, but also women that were CASO members at the time, understand what was a safe space for women. In 2020, we went on with our activity and we went exclusive about women with a mutual support group. And 2021 was the year of the feeling was already that the group was feeling like a group. And in 2022, we organized with GATT and with Women Harm Reduction International, with RIN, to monitor and to gather information and to write a shadow report about the issues that are affecting women who use drugs in Portugal. 2022 was for Musa the year of putting together this shadow report, all the information, and then going to Geneva to present and advocate for and recommend and advocate for the needs of women who use drugs in Portugal. And the discrimination was proved. The violation of rights of women who use drugs was evidenced. Also about gender-based violence, access to health care, and also parental custody rights and judicial sentencing. So, finally, and I have to finish because I have no more time, I want to tell you what was the situation that was found in Portugal in 2022 about the issues affecting women who use drugs in Portugal, and what were the recommendations that the community of women who use drugs in Portugal made to CEDAW, to the Committee of the Elimination of Discrimination of Women, and CEDAW would return to the Portuguese government with these recommendations. It was not exactly what happened, but I want to show you what we have recommended. About gender-based violence, we recommended that the providence of violence prevention support for survivals, for women victim survivals, for women who use drugs, through harm reduction services. Women will not be able to make all the way to the services if the harm reduction services won't support and won't enhance this possibility. Also, to provide mechanisms for reporting violence and restitution through justice. And the mechanisms must be safe, must be effective, and must be respectful. The respect is also, and there are many questions around this, is on the I'm lacking the word, I'm sorry. Well, it must be
on the demands that the group had, maybe.
Yeah. Well, it's not, if things are known by the services, if a woman who uses drugs, the health, the child protection faces this situation like this, it is very probable that it will be a very difficult situation. So these mechanisms of reporting violence and restitution of justice must be safe, effective, and respectful in this way. It cannot be something that will come back to the woman in a punitive way. This is the sense. And on the access to harm reduction, to treatment and health services, the recommendations to the Portuguese government were about the adequate resources for women-specific harm reduction services. The government must provide the adequate resources. The existing harm reduction services must be adjusted, and harm reduction and other prevention programs, HIV and HCV, must to allow a greater uptake by women who use drugs, by, for instance, hiring female staff, providing on-site childcare support, women-specific information, education and communication resources, flexible service hours, and expanding fixed-site healthcare to include mobile outreach services. Also ensuring the meaningful involvement of women in the design, implementation, and evaluation of services.
So I would like to thank you, Lígia, first of all, for your time for preparing and collecting, putting together all this information. Thank you, everybody, for taking part and taking your time to participate at this workshop. And I hope to see you at the future core workshops. Have a great day.